start until 1:30, and we were wondering whether people were sort of thinking it was 1:30 today. But it's supposed to be 1:15, so I thought I would try to sort of start things at any rate. Sounds like it's been a great morning, and I just want to welcome everyone back. My understanding is that there is a raffle, and this is from Lifeline Healthcare, Inc., and it's for a wonderful gift certificate, a restaurant gift certificate for the Cone Restaurant Group. And I've been asked to read the winner, and the winner is Marie Naughton. Ah, great. All right, Marie. Great. Great, congratulations. All right. So now we have to get serious, I guess. I'm Jody Corey Bloom. I'm a neurologist at UCSD. And what we're going to talk about in the next, I think, half hour or so is dementia diagnosis. And it sounds like the people who put this together weren't sure whether I was going to do diagnosis or case studies or whatever, so I apologize. I'm going to try to get through diagnosis in 30 minutes. All right, so we need something to advance. Let's see. Maybe way up here. There we go. Okay, and just to the left? Okay, great. I got it. Thank you. Perfect. Thanks, Bess. That's good. Thank you. Okay. All right, so we're going to talk a little bit about dementia diagnosis, and I want to start first with disclosures. I am the principal investigator on several clinical trials for dementia and have received various pharmaceutical organizations' support. All right, so differential diagnosis of dementia. So there are obviously many causes of dementia in the elderly, and differentiating the various dementias can be pretty challenging. But far and away, the most important cause of dementia in the elderly is Alzheimer's disease, comprising about 65% of most series, or really depending on the series. And I'm often asked, so what is it that clinicians really do when they're confronted with a patient with cognitive complaints, or a family with complaints about a patient with cognitive difficulties? And I think what we really do is try to determine whether cognitive impairment actually exists, and if that cognitive impairment meets criteria for dementia. And one of the things I usually or often notice is that families will say that somebody is confused, and that word really isn't all that helpful sometimes, and it really falls to us to figure out what that means. Does it mean that they have short-term memory difficulties? Does it mean that they're having attention problems, concentration problems? So that word confusion isn't necessarily helpful, and what we really have to do is try and identify the real nature of the cognitive problem. We have to try and assess associated clinical features, and then of course initiate the evaluations necessary to determine the etiology of the dementia. I also like to remind myself that the diagnosis of dementia really is still a clinical judgment. With all of the exciting things, and we'll hear about imaging with Jim Brewer next, the truth of the matter is that there really is no specific test that says that someone has dementia or what kind of dementia. And in the end, we really do rely on clinical criteria and a good clinical assessment. That clinical assessment requires a skillfully taken history, preferably with an informant, assessment of clinical features, mental status testing, and then of course neurologic exam. We usually end up doing some laboratory testing and also some neuroimaging, either a non-contrast CT scan or usually an MRI here at UCSD because they charge the same amount, so we might as well get some more information. In some instances, we often have to do neuropsych testing because a person might be very high functioning or there might be depression, and we really don't know whether or not there is actual cognitive deficit. So obviously this takes a lot of time, it obviously takes money, and done well can actually really, I think, give us the information that we need. So what about that skillfully taken history? What kinds of questions do you need to ask? Well, first of all, we really need to have it corroborated by an informant, if at all possible. We really want to try and establish whether or not there's a change from a prior level of intellectual performance. So if someone could never do something, demonstrating that they can't do something now isn't really that helpful. You really need to make sure that it was something the person could do beforehand. Is there a change in functional abilities, things like meal preparation, games of skill, financial matters? And is there a family history of dementia? You want to assess associated clinical features. You want to talk about the tempo of the cognitive decline. Did it come on abruptly, or was it really subacute or very slow? Are there associated behavioral features and psychiatric features? And then, of course, you want to do some mental status testing. I'm often asked what the best testing is, and I think it really is the preference of the individual physician, but it should include assessment of attention, orientation, recent and remote memory, language, praxis, visual spatial abilities, calculations, executive functioning, and probably no surprise that many clinicians use a brief mental status screening instrument often, maybe supplemented with additional tests, because it sort of incorporates sort of all of these things and allows you to do these assessments reasonably quickly. So, for example, something like a mini mental state examination, it's not unusual for clinicians to do that. It's 30 points. It takes about 10 minutes to complete. There are 10 points for orientation, 3 points for registration, 5 points for attention and calculation, 3 points for short-term verbal recall, 8 points for language, and 1 point for visual spatial abilities. And so you see here the intersecting pentagons. That's very commonly, or that's a very common actual visual spatial test, and is a part of this mini mental state exam. And you can see here, for example, a not well done intersecting pentagons. Some people actually prefer the MoCA, the Montreal Cognitive Assessment. I like it. One of the really best features of it is it seems to have a little bit more executive functioning, so that's good. And also it has it has a word list, which is actually quite good, and there's a built-in delay. So you give the person a list of some words, and then a few minutes later you ask them to give you those words back. So it's actually delayed recall, which is actually very sensitive. And of course, clock drawing. And what you see here are some examples of clocks that are not drawn well. Obviously, poor planning in these clocks. Now, the neurologic exam is often normal, especially in early Alzheimer's disease. And in fact, I think if you see significant or lateralizing abnormalities, such as maybe right-sided weakness, left-sided weakness, a visual field cut, that it really should suggest a diagnosis other than Alzheimer's disease. The kinds of things that you can see in intermediate or advanced Alzheimer's disease, extrapyramidal symptoms, things like rigidity, bradykinesia, sometimes some non-specific gait disturbances, frontal release signs, a snout, for example, and myoclonus, sort of shock. Clinical evaluation includes laboratory testing, and I think pretty routinely we get things like a CBC chemistry panel, vitamin B12, thyroid function tests, in some instances syphilis serology, and then some kind of imaging, as I mentioned, and of course, when indicated, some of these other examinations. We usually do structural neuroimaging, as I mentioned, either a non-contrast CT or MRI. And basically what we're trying to do is exclude some kind of a treatable lesion, a brain tumor, a subdural hematoma, for example. And when you find things like cortical atrophy, ventricular enlargement, or some non-specific white matter lesions, it's often hard to know what to do with that information because that tends to overlap with normal aging quite a bit. Volumetric MRI, which is available through our center and through actually a local imaging center, can actually help because it gives you a quantification of the size of the hippocampus and also the size of the ventricles, and really does give you a good idea as to where that person stands. And functional neuroimaging, things like SPECT and PET, we don't usually do these obviously routinely, and I think the most common use really for PET and SPECT is really in distinguishing Alzheimer's disease from FTD, although you'll hear from Dr. Brewer about amyloid imaging in the next talk, and that's actually pretty exciting, imaging the brain amyloid with various compounds. I can't emphasize enough the importance of evaluating and really reevaluating for depression and metabolic disturbances, endocrine disorders, systemic illnesses, and of course medications that patients are taking. This is really, really important. All right, so having done all of that, we then have to start to think about the clinical features and what we think is going on. And I think obviously when patients present with early impairment in recent memory, we're thinking about something like Alzheimer's disease. When they present with associated Parkinson's disease and especially hallucinations or psychosis, we're thinking about something like Lewy body dementia. When they present with language or behavioral deficits, fronto-temporal dementia, and then of course the onset of deficits following stroke, things like vascular dementia. So I think that's sort of a kind of a brief outline of the way we sort of tend to think about it, and now let's talk about it a little bit more in depth. So Alzheimer's disease, as I know you know, presents with early impairment in recent memory. Usually long-term memory is very much intact. It's really the thing that people have the most trouble with is recent memories, yesterday, today, those kinds of things. And AD progresses really through very distinct phases or stages. In the earliest stages, you do see, as we mentioned, the short-term memory problems. There might be some mild dysnomia. In fact, they may be able to tell you the name of the watch or the pen, but maybe not the small parts of it. So maybe not the band or the stem or the point. So those kinds of things, they have a lot of difficulty giving you that name. They may be a little bit hesitant, a little bit disfluent, searching for words. There may be some associated depression. There may be some diminished judgment. As the disease progresses, they now begin to have trouble learning new information, and long-term memory becomes affected. They become more non-fluent. They begin to have trouble comprehending what's being said to them, and that's really quite startling when that begins to happen. There are behavioral and personality changes, wandering, and agitation. And then as the disease becomes even more severe, patients can become quite mute. They may develop gait or motor disturbances. Because of that, they may become bedridden, incontinent, unable to perform ADLs, and this is really when nursing home placement occurs. How about risk factors for Alzheimer's disease? Very importantly, age. Age is probably the most important risk factor for Alzheimer's disease. There are genetic influences, the importance of somebody's ApoE status, female gender, lack of education, and even head trauma. There have been many biomarkers proposed for Alzheimer's disease, the genetic one, the ApoE allele, the apolipoprotein E allele, but also markers in the cerebrospinal fluid, beta amyloid, an important constituent of the plaque, total tau, an important constituent of the tangle, and phospho-tau. And then in terms of neuroimaging, things like structural MRI, particularly smaller hippocampus or medial temporal lobe, for example, and then global atrophy, PET, both FDG and amyloid PET, and even SPECT. And as I'm sure many of you know, there are very typical patterns that one can see on functional imaging. So this is actually PET on the left. This is a PET slice. This is the front of the brain, the back of the brain. This is actually a SPECT slice. And what you can see is a lot of activity, the areas of red in the frontal areas. But then right here and right here, this is the temporoparietal area, you see much less activity. And even here on the SPECT, again in the bluer areas back here, that pattern of temporal parietal hypoperfusion or hypometabolism. As Dr. Brewer will tell you about, we now have a very exciting advance, and that's the imaging of amyloid in vivo. And so we can now use PET to actually image fibrillar amyloid plaques in the brain, and he'll spend probably the next half hour telling you about that. So I will move on quickly. The one thing I would say is that we know now that the uptake that we see in life actually mimics quite well the distribution of plaques in the brain at autopsy, so that's actually quite reassuring. Unfortunately, it may be less useful for progression, but we'll let Dr. Brewer talk about that. We do have criteria for Alzheimer's disease. We have DSM-4. These are really quite old criteria. This was then followed by the NIN-CDS ADRDA criteria, which really was fairly similar, required deficits in 2 or more areas of cognition, progressive worsening, and really no other disorders that could actually explain the deficits and the progression. And most recently, new diagnostic guidelines for Alzheimer's disease. These are Mecanidol in 2011, and these are actually criteria that are flexible enough to be used by both clinicians and researchers, but actually incorporate biomarker evidence into the diagnostic formulations. And this is really a modification after Sperling and Johnson that was published in 2013, looking at AD and MCI criteria, incorporating these biomarkers. And essentially what it shows is if you look at A-beta markers, whether it be PET, the amyloid PET scans, or CSF, cerebrospinal fluid, the amount of beta amyloid in the CSF, or if you look at neuronal injury biomarkers, things like CSF tau, FDG PET, or structural MRI, if you have A-beta and neuronal injury biomarkers that are positive, there's a very high probability that that individual's dementia is due to Alzheimer's disease. And likewise, if you have negative neuronal injury and negative A-beta markers, there's really a very low probability. It's pretty unlikely that that person's dementia is due to Alzheimer's disease, with various in-between. So as treatment has begun to focus sort of earlier and earlier, we've really sort of paid a lot more attention to the continuum between normal aging and Alzheimer's disease, and have now recognized an in-between stage, the so-called MCI, or mild cognitive impairment stage. This is a transitional state. It probably does affect about 15% of older adults. It definitely increases in prevalence with age. Like Alzheimer's disease, there are subtypes, and probably the subtype that we know best is amnestic MCI, in which the person has memory impairment but minimal to no other cognitive losses. And so if you have a patient with short-term memory difficulties, and really pretty much everything else is very intact, and they also have really preservation of everyday function, it's probably best to call this person mild cognitive impairment rather than Alzheimer's disease. Now, mild cognitive impairment can result in stabilization in some patients. Some patients with mild cognitive impairment can actually improve, but a large number, especially amnestic MCI patients, progress to Alzheimer's disease, and I think this is really driven home by these conversion rates to probable AD. The conversion rate for normal elderly, about 1 to 2% per year, whereas the conversion rate for MCI, about 10 to 15% per year. So clearly MCI is a risk state for the development of Alzheimer's disease. So if you're thinking someone might have Alzheimer's disease or MCI, it's really important to specifically inquire about cognitive, psychiatric, behavioral, and functional symptoms. It's important that in your cognitive assessment you have some good measures of short-term recall, preferably a delayed list. It's important that in terms of neuroimaging, that you look for loss of hippocampal volume. If you do functional imaging, perhaps temporoparietal hypoperfusion. And of course, as Dr. Brewer will tell you about, the amyloid scans looking for fibrillar amyloid, or also CSF examinations looking for low levels of beta amyloid in the cerebrospinal fluid. Now, what if your patient, on the other hand, presents with early Parkinsonism? They really look like quite Parkinsonian, perhaps even have visual hallucinations or visual spatial problems. Most likely you're dealing with something like Lewy body dementia. And Lewy body dementia is a dementia, but unlike Alzheimer's disease, where memory is an important cardinal feature, especially short-term memory, in Lewy body dementia, it's really more attention, executive function, visual spatial problems. And there's actually a relative preservation of memory. And in fact, I think that's driven home here by this study that's actually now probably almost 15 years old, just looking at something simple like pentagon copying. And what you can see here is actually an attempt at pentagon copying by somebody with a mini-mental state examination score of 29. And they are unable to even draw those intersecting pentagons. That should cue you right away when you see such visual spatial deficits that you might be dealing with something like Lewy body dementia. Other core features include fluctuations in attention, recurrent, well-formed visual hallucinations, as I mentioned, and Parkinsonism. And the visual hallucinations are recurrent, they're complex, they occur very early. And don't forget, you can see visual hallucinations in Alzheimer patients, but you don't see them so early. You usually see them in the moderate stages of Alzheimer's disease. So when you see it very early, you really would also think about something like Lewy body dementia, and oftentimes the visual hallucinations are associated with reduced occipital uptake in the visual cortex. And we said before that the pattern of hypometabolism in Alzheimer's disease is temporoparietal, all right? And what you're going to see is that this dementia, Lewy body dementia, moves back further. So Lewy body dementia doesn't involve the temporoparietal areas, it involves the parieto-occipital areas. So this is really a further back dementia, if you will, in the brain. The Parkinsonism has an axial tendency. There's lots of postural instability and gait difficulty. You don't see so much of that resting tremor like you do in idiopathic Parkinson's disease. So the resting tremor is much less common. And the fluctuations that we talk about is really not so much, well, do they have good days and bad days? Because you can see that in Alzheimer's disease too. In my mind, this is really a lot more like variations in arousal. All right, attentional performance, yes, but really arousal. Sometimes these people become almost comatose, Lewy body patients, and so it's really variations in arousal. What else do you see in Lewy body dementia? You see REM sleep behavior disorder, and you can see pretty severe neuroleptic sensitivity. So it's important to identify these patients before you give them too much in the way of neuroleptics. Brad Bouvet some time ago asked the question, what is the likelihood of having REM sleep behavior disorder in Lewy body dementia and Parkinson's disease versus Alzheimer's disease? And so whereas in Alzheimer's disease it's about 2%, he found that it was almost 60% in DLB and PD. So this is a very common feature and often predates the onset of the Lewy body dementia. What you see here is actually differentiating DLB from Alzheimer's disease and normal controls using a SPECT dopaminergic presynaptic ligand. This is known as beta-CIT. This is a special kind of a functional scan that uses a marker for presynaptic neuronal degeneration. You see here in the normal control, very intact striatum. You see here, even in the Alzheimer's patient, a very intact striatum compared to the Parkinson's patient and the DLB patient. So the striatum clearly takes quite a hit in these patients, and you can demonstrate it with the beta-CIT. Another thing that you can demonstrate is with myocardial scintigraphy is a loss of postganglionic sympathetic cardiac innervation. There's a lot of autonomic nervous system involvement in Lewy body dementia. It's quite different from Alzheimer's disease in that way. And what these folks are looking at here is the heart to mediastinal ratio. And you can see here early and also delayed patients with Alzheimer's disease in the green, early and late, patients with DLB in the pink, again, early and delayed. So much lower ratios suggesting a loss of postganglionic sympathetic cardiac innervation in these folks. And so we mentioned the autonomic dysfunction. There's also syncope, transient loss of consciousness, again, that loss of arousal, if you will, or decreased arousal. And what we also see in these patients is preservation of medial temporal lobe on neuroimaging. And in fact, it's kind of pretty well demonstrated here. This would be much more like what you would see in an Alzheimer patient. This is the medial temporal lobe on one side and the other. You can see that there's a large temporal horn, a very small hippocampus. As compared to up here, this would be much more common in a Lewy body patient to see a much more intact medial temporal lobe, a much more intact hippocampus, and a much smaller ventricle there, or temporal horn. But another thing that was really demonstrated, I think, quite nicely by Whitwell is not only is there an absence of medial temporal atrophy, there's also an absence of cortical atrophy in Lewy body dementia. And so in Alzheimer's disease, which you see over here on the right side, you can see the areas that are in red are areas where there's pretty significant atrophy compared to normal controls. So demonstrated nicely, really, this lateral area, parietal, temporal areas, lots of atrophy. But now look at the Lewy body patients versus normal controls. You see very little demarcated in the cortex with regard to atrophy. So there's much less cortical atrophy, much less medial temporal lobe atrophy. When you look functionally on things like PET or SPECT, you see a pattern of occipital hypometabolism, again, back of the brain. And you can see that sort of right here. This is the front of the brain, the back of the brain. So occipital, parieto-occipital hypometabolism here, and on SPECT, occipital hypoperfusion. So parieto-temporal areas for Alzheimer's disease, occipital areas for Lewy body dementia. So when we think that someone might have DLB, it's really important to specifically inquire about cognitive, psychiatric, sleep, behavioral, motor, and autonomic symptoms. In your cognitive assessment, it's important that you include measures of attention, executive function, and visual spatial ability. In terms of neuroimaging, you're going to see preservation of hippocampal and other cortical volumes. You may see occipital hypoperfusion on functional neuroimaging. And how about patients who present with dominant language or behavioral deficits? Dominant language or behavioral deficits. These people probably have a fronto-temporal dementia, okay? So this is not short-term memory. Instead, this is language. They're presenting with language problems and behavioral problems. The fronto-temporal dementia, you can see the brain of a patient with FTD here. This is nice, lush, posterior part of the brain, looks good. And then look up here, anteriorly, you can see these sort of knife-like gyruses because of all the frontal atrophy that's present. FTD is a very common cause of dementia below the age of 60. There is a family history in up to 40% of these patients, and the commonest mutations are MAPT and the progranulin. This is really an umbrella term for a heterogeneous group of clinical disorders. There is a behavioral variant FTD. There is a progressive non-fluent aphasia FTD. There is semantic dementia. But in all cases, you're really dealing with variations on behavior and language. So as we move forward, behavioral variant, again, not surprisingly, it's the behavior that takes front stage here. Things like apathy, submissiveness, social withdrawal, depression. There may be disinhibition. There may be compulsions, dietary change, for example. Cognitively, you may see frontal or executive dysfunction, perseverations, maybe some diminished word output, and often behavioral variant FTD is associated with other neurologic syndromes, things like motor neuron disease, ALS, Lou Gehrig's disease, PSP, progressive supranuclear palsy, and cortical basal syndrome, cortical basal ganglionic degeneration. I should go back for one sec. In terms of imaging, you're going to see bilateral frontal or anterior temporal lobe abnormalities in those patients, as seen here. I'm going backwards. All right, as seen here. Sorry. So this is structural neuroimaging, and you can see this is the front of the brain and the back of the brain. This is a CT scan. And you can see this back of the brain looks pretty normal. This back of the brain looks pretty normal. But up here, there's lots of atrophy in the front of the brain, lots of shrinkage, and so there's lots of areas that are filled with fluid because of the shrinkage in the frontal lobes. And then even on this functional scanning, the PET scanning, you can see that anteriorly there's much less activity than what you see posteriorly. So this is now a frontal dementia, a frontal lobe dementia. Progressive non-fluent aphasia is one of the other common frontal temporal dementias. Behavioral symptoms are much less common. These people really have lots of language problems. So behavior isn't the main thing. It's really language that is the main thing. Diminished verbal fluency. They have pronunciation difficulties. They have word-finding problems. They're agrammatical. They may have phonemic paraphasia, some stuttering, impaired repetition, speech apraxia. There may be some associated executive and working memory dysfunction. They can have some of the motor features of PSP and corticobasal syndrome, and on imaging you will see left perisylvian atrophy. These are actually coronal sections. This is actually the right side of the brain, the left side of the brain, again the right, the left. If you kind of start to compare the right here to the left, you see there's a lot more atrophy on the left. This is a pretty reasonably intact right side, but a little more atrophy here on the left. And again, here you can see that left frontal opercular or perisylvian atrophy. And then finally, semantic dementia, always one of my favorites. It's really interesting. This is also a lot of language involvement, less behavior, but a lot of language involvement. There could be some coldness or emotional withdrawal. But in general, these are people who've really lost word meaning. So words have lost their meaning to them. So if you say to them, "What's a comb? Tell me what a comb is." They'll say, "A comb? A comb? I don't know what a comb is. What's a comb?" You say, "Well, it's something that you run through your hair to kind of put it in better order." And they'll say, "Oh, comb, okay." So they've actually lost that connection between the word or the name and what the actual item is. A real loss of word meaning. So they have difficulty naming, difficulty recognizing words. As a result, there may be idiosyncratic word usage, semantic paraphasias, sometimes loss of facial recognition. This can be asymmetric or symmetric, but interestingly, seems to primarily affect the anterior temporal lobes. And what you can see here in this next imaging horizontal slice, you can see this is the front of the brain and the back. There's some eyeballs. Right here, this is the anterior temporal lobe on the right side, anterior temporal lobe on the left side, and there's lots of atrophy of both anterior temporal lobes. And this is pretty common in semantic dementia. So aside from the three main kinds of frontotemporal dementia, the behavioral variant FTD, the progressive non-fluent aphasia, the semantic dementia, there's really been increasing recognition of other features and syndromes that occur in the setting of FTD. As I mentioned, PSP, corticobasal syndrome, and also motor neuron disease. PSP, as I think most of you know, involves akinesia, rigidity, a lot of vertical supranuclear gaze palsy, lots of early falls, and apathy. And in fact, it's pretty common that you can diagnose PSP from the history. The family will tell you they've just been falling all over the place, falling, falling, falling. And then you look and you see that supranuclear gaze palsy. Maybe there's a little bit of a history of swallowing difficulties or dysarthria sometimes, and you've got your diagnosis of PSP. Corticobasal syndrome, usually asymmetric, one side, left side, right side, rigid, dystonic, half of the body. Almost the person might even look like they're sort of carrying that side of their arm, for example. It can become so bad that they may develop an alien limb syndrome. They may not believe that that limb is their limb and belongs to them. So it's usually a very asymmetric kind of a syndrome. There may be some myoclonus, and speech is often non-fluent or stuttering. In motor neuron disease, there can be bulbar symptoms, dysarthria or dysphagia. There can be, in ALS, for example, or Lou Gehrig's disease, there's upper motor neuron and lower motor neuron. Sometimes the motor neuron disease that's associated with FTD is just lower motor neuron. It's not always both. There can be both, though. There can be weakness, spasticity, hyperactive reflexes, and the motor neuron disease can even precede the development of the frontotemporal dementia. So it can precede, it can coincide, or it can follow the development of the dementia. Just to tell you that the pathology is all over the place for these syndromes and would probably take a whole other discussion, but there are many different pathologies that are associated with the frontotemporal dementias. So if you're thinking FTD, it's really important to specifically inquire about cognitive, psychiatric, and behavioral symptoms. Also age of onset. These patients tend to have their age of onset in their 50s. It's pretty common that they're fairly young. And I actually had a patient not that long ago that was actually in her 20s and died by the time she was 34. So it's really an early dementia. In terms of the cognitive assessment, you really want to make sure you're looking at executive function. You want to look carefully at language because those are the two things that you see affected. On neuroimaging, you're looking for frontal and maybe anterior temporal atrophy, frontal hyperperfusion. So frontotemporal dementias affect the frontal lobes, Alzheimer's disease, parieto-temporal, and then Lewy body dementia, the parieto-occipital area. So very different areas of the brains affected with these very different dementias. And then I hesitate to say much about this because we have Dr. Helena Chua speaking to you about vascular dementia in a little bit, and she's going to do a very wonderful job. But I just want to mention quickly vascular dementia, since I'm often asked about it. What you see here is really the onset of deficits with stroke. And we used to always say that it would sort of abruptly follow stroke, and I think with certain kinds of large stroke that can be, but sometimes there are vascular factors that occur kind of more slowly or more subacutely, and we're not as aware of it. Sometimes we just see evidence of stroke on scan, and the person really has no specific history. So when we see the deficits with stroke, we often think about vascular dementia. And this is very heterogeneous. I just want to say a few things about it. The dementia syndromes are accompanied by evidence from clinical history, neurologic exam, and neuroimaging of cerebrovascular lesions, kind of causally connected to the dementia. There's a variety of clinical presentations that you can see, a variety of pathophysiologies. Pure vascular dementia is probably rarer than we thought, but the majority, but there is a lot of vascular pathology, I guess I should say, in a good percentage of population-based dementia cases. When you look at vascular dementia, as I mentioned, less than a third will really represent pure syndromes, and the majority are associated with other pathology, often Alzheimer's disease. And this is a clinical pathologic study of heart and brain lesions in vascular dementia from Lund University Hospital, published in 2005. This was in Sweden, and they looked at 175 clinically diagnosed vascular dementia cases who came to autopsy. And what they found was that only 28% of those patients were pathologically classified as pure vascular dementia. The remaining 72% showed AD pathology in addition to a mixture of vascular lesions. I think probably the most important thing that's occurred in vascular dementia over all these years that I've sort of kind of been looking at it is a name change, and I like the name change. We really call it vascular cognitive impairment now, and I think that that's very important because it's probably come out of the recognition that the prevalence of cognitive impairment caused by vascular disease is underestimated. When we used to talk about vascular dementia and the criteria for vascular dementia, you're sort of really focusing, if you will, kind of right here on the development of dementia after the sequelae of stroke, okay? With the notion of vascular cognitive impairment, you're recognizing this important earlier stage, if you will, and the notion of risk factors in a susceptible host, so-called brain at risk, so a much earlier look at it. And I think the importance of vascular cognitive impairment is that vascular disease is really the largest single identifiable risk factor for dementia apart from age, and it's treatable. I mean, there are some non-modifiable risk factors, for example, age and gender, race, ethnicity, but there's a whole lot of modifiable risk factors: hypertension, diabetes, heart disease, especially atrial fibrillation, cigarettes, and heavy alcohol use. And I think this article from Gorelick et al. In 2011 sums up a lot of the importance of the construct of vascular cognitive impairment. First of all, they note that cerebral amyloid angiopathy is emerging as an important marker of risk for Alzheimer's disease and vascular cognitive impairment. That the neuropathology of cognitive impairment in later life is often a mixture of Alzheimer's disease and microvascular brain damage. That the risk factors for vascular cognitive impairment are probably the same as the risk factors for stroke, and vascular risk factors may also be risk markers for Alzheimer's disease. Again, important. And so if we can detect and control the traditional risk factors for stroke and cardiovascular disease, we may be able to prevent vascular cognitive impairment. So I think you're all beginning to look a little like this. I'd like to actually thank you for your attention. You've been a really great audience, and thank you very much. Bye. So we are